Good afternoon, everybody. Thanks for joining us for our Sooner Select Medical Town Hall. I'm Kevin Corbett, CEO of the Oklahoma Healthcare Authority. And as many of you know, the Healthcare Authority's mission statement expresses the importance of optimizing accessibility and quality of healthcare and improving health outcomes for Oklahomans. The sad news is, however, our state continues to be ranked at the bottom of the list in health outcomes, including obesity, cardiovascular disease, diabetes, substance abuse, suicides, and many more. It is our intent to improve health outcomes through a new delivery system that by now, hopefully you've heard about, which is called Sooner Select. This is a change in the delivery system that has had great collaborative effort amongst many stakeholders, and we're very optimistic about what we're going to be able to achieve. Today, you'll hear from Traylor Rains, our state medical director, who will give you a detailed rundown of the new delivery system. Following that, we'll open it up for questions and look forward to your input. But without further ado, let me turn it over to Traylor.
Thanks, Kevin. Afternoon, everybody. Thanks for joining us. I show that we have just over 170 folks joining us today, which makes my public policy heart very happy. Just kind of wanted to go through some of the highlights of the Sooner Select program, give you a snapshot of what you can expect to see, some of the changes maybe that we are going to implement over from the product that we were moving forward with last year, and then have some time available for Q&As. If you have questions throughout the presentation, feel free to drop those in the Q&A box, and we will do our best to either answer those during live Q&A towards the end or answer them live by staff in the background. All right, let's get started. So what are the key provisions of Sooner Select? So as Kevin mentioned, as a state, we've made a lot of progress in addressing a lot of the outcomes for Oklahomans, but we still kind of rank in the bottom 10 in a lot of those outcomes. And we want to improve the overall health of all Oklahomans, but specifically the members that Sooner Care serves. We want to do this by moving towards a value-based payment methodology and away from payment based on volume. If you're a provider with Sooner Care now, you know that if you provide a treatment service, you're going to submit a claim for that service, and we're going to reimburse you for that service. We have some value-based payments through maybe our Sooner Excel program if you're a patient-centered medical home. But really, outside of a few examples, we don't really have pay for performance or pay for outcomes. And so we want to move the program towards that direction. Along with this, it's important to us to improve Sooner Care beneficiary satisfaction. So how happy are members not only with the services they're receiving from their providers in the community, but also how happy or unhappy are they with the services that the Healthcare Authority provides? And we want to bring in additional resources to make sure that we're optimizing the satisfaction for the members and the providers we serve. Of course, we want to contain costs through improved care coordination of services. We know that when individuals have access to the services that they need at the right time where they're at, that they're more likely to access those lower levels of care and access preventive services with their primary care providers, which therefore avoids those higher, more intrusive emergency room visits or inpatient visits that we know cost the system more money. We also want to increase cost predictability to the state through the Healthcare Authority's budgeting process. So as I mentioned, and I'll go into more detail around capitated payments, but as I mentioned, we're very volume-based now. We get a claim and we pay that claim. We're going to transition into more of a per member per month that we will pay to a third-party administrator or a contracted entity, and we know how much that's going to be on a monthly basis. And it'll be a risk-sharing relationship between us and our contracted entities as we move forward. So what is the program going to look like? What's the program design? So some key abbreviations here that you'll see as we send communications around Sooner Select, or when we drop the request for proposal later this month, you'll see certain key terms, and I just kind of want to walk through a couple of those. One of the key design evolutions of Sooner Select from last year as we go into this year and through the authority given to us by the legislature and the governor through Senate Bill 1337 is that you'll see us referred to as Oklahoma provider-led entities. That's a key difference. We know we have commercial plans in the market. We have HMOs, and we also have a provider-led entity. And what that is essentially is an organization that is majority owned or majority governed by Oklahoma providers. And by providers, that can be primary care providers, hospital systems, behavioral health care providers, just the providers in the community that come together, maybe partner with a commercial plan, for example, to do kind of the back office functions. They will be eligible to apply to the RFP to become a contracted entity to be a Sooner Select provider once we go live. So I mentioned a while ago, Senate Bill 1337, that's our legislative vehicle that gives the Healthcare Authority to move forward with Sooner Select and directs us on how to approach the program, the key requirements of it, and some provider protections to ensure that our providers are taken care of through this transition. So 1337 requires the Healthcare Authority to award several types of entities at least 3 statewide contracts. We understand the importance of having a statewide solution. As many of you know, or may have heard, we did operate a managed care model back in the late 90s. And one of the things that we're trying to fix from the first go around there is having a statewide solution and not having that urban rural split or differential. Now, there is one exception to that. We understand that the provider-led entity model is still going to be fairly new in concept, and we want to kind of allow for entry into the market by a provider-led entity since they may not have the level of maturity that a established commercial plan does. And so we would award an urban region to a provider-led entity with the expectation that they meet statewideness within a 5-year period. So if a provider-led entity applies to be a contracted entity through the RFP process, we would evaluate that, their RFP, make sure they meet all the basic requirements, and then really look to that operational plan and timeline to make sure that they have a solid timeline with achievable milestones to reach that statewideness requirement within that 5-year period. Now, I will say too that if we do award an urban region to a PLE, that is, an urban is defined as Oklahoma City or Tulsa areas, as well as those contiguous counties there too. That is not exclusively awarded to a PLE. Now, that would also be in addition to any of our statewide products that are awarded. So, for example, if we have 3 statewide contracts and 1 urban contracted entity in Tulsa, that means we would have 4 contracted entities technically covering the Tulsa metro area. So in addition to that, we have certain expectations for our contracted entities moving forward. In fact, at last count, I think the RFP is up to around 450 pages. So we have a lot of expectations for our contracted entities. So I'm only going to name a few and kind of touch on the highlights. We know that the Healthcare Authority has gained a great reputation among our provider community over the years, and our program enhancements and how we ensure, for example, that we make timely payments to our provider community. Our providers know that they can count on, if they submit a clean claim by a certain time, 1 week, that they will receive payment for that claim the following Wednesday. Our providers rely on that. It's a good cash flow and keeps the doors open in a lot of cases. So we want to make sure that that protection carries on in a Sooner Select model through our contracted entities. One of the provision that directly addressing this will be that the contracted entities pay within 14 days. We know that's beyond the current week turnaround, but I will say that when we went through this process last year, we actually saw our plans being able to pay even quicker than the Healthcare Authority does. And sometimes if they submitted it by a certain time, one day you could even be paid potentially that evening. Along with that, we know that it's important that we have timely responses on our prior authorization requests. We want to remove or reduce any barriers that we can for our members to access service. And that means that once a provider submits a prior authorization request, that we're turning those around timely. The Healthcare Authority also prides ourselves on being able to do that within a fairly short time frame on most services, and we will also pass that along as a requirement to our contracted entities. We also have very specific quality metrics related to improved health outcomes. Again, one of our major goals, number 1 goal on our slide earlier, was improving those health outcomes for the members we serve. So of course, we're going to have very specific core measures that we're going to expect our plans and contracted entities to achieve throughout the life of the contract term. There will also be a requirement that our health plans submit data to the Health Information Exchange when it goes live. We know it's important for care coordination that we have a good, broad, global perspective of the members we serve, and that means having access to all their health records across their lifespan and continuum of care. And we know how important that HIE will be to that process. Really important here to focus on is a requirement that our contracted entities spend 11% of their medical spend on primary care. Now, this is going to be a requirement that needs to be achieved by year 4 of the contract period. To give you a little perspective, current contract spend around primary care in the healthcare authority in our administration is just over 4%. So that's going to be quite a lift. But again, we also know that when members are accessing primary and preventive care services, those are really what's going to avoid those higher cost services or avoid an exacerbation of a clinical process or a disease that member is experiencing. And we know how important it is to get upstream and ahead of the curve with a lot of these disease processes. So we know it can be achievable, and we'll work closely with our plans to help them reach that goal by year 4. Population. So who exactly is going to Sooner Select? I will say there's a few slides on this that gives you all the details about these populations. But in short, the folks that are not going over to Sooner Select and will keep being taken care of and have their care administered through the healthcare authority are age blind disabled populations, nursing facility members, those being served through an intermediate care facility, and a few others. But who is going over? That's going to be our Sooner Care kiddos, deemed newborns, our pregnant moms, parent caretaker relatives. That's those parents taking care of a child that's eligible and on Sooner Care with a very low federal poverty limit income threshold. Also our expansion populations, those the members that we started enrolling last July, at age 19 and 64, children in foster care, former foster kids up to 25 years of age, juvenile justice involved kids, and children receiving adoption assistance. I'll point out here specifically with regard to a child welfare population and our juvenile justice involved, that we will actually have a separate RFP going out this year for our children's specialty plan. If you were involved in this process last year, you may remember that as an addendum to a medical plan, we were also awarding a children's specialty plan to one of those successful vendors. And this plan is specifically focused on care coordinating and meeting the needs of kids in the child welfare system and otherwise in the custody of the state. We know that these kids have very unique services that are often a lot more elevated than a general population. We know that there's higher levels of trauma, higher levels of behavioral health needs, and we want to make sure that those kids are being able to access the right amount of care to address their needs very early on and coming into the system. So we will have a separate RFP this year that will not be part of another main medical plan, but it will be a standalone plan. Important to note here is that our American Indian Alaska Native members will be able to voluntarily enroll into Sooner Select. It will not be a mandatory requirement for those members to come to be auto-enrolled into Sooner Select, but they will have the choice to participate if they so choose. So who are those excluded individuals? I mentioned broadly earlier, it's our ABD, our age blind disabled members. The folks on the next couple of slides really account for about 20% of our overall population. So after the public health emergency ends, we expect this to be just around 200,000 individuals that would be excluded from Sooner Select and still have their care administered through the healthcare authority. That's also our duly eligible individuals, those that have Medicaid and Medicare for their healthcare coverage. Individuals enrolled in a Medicare savings program, qualified disabled workers, qualified QI, the QI population, as I mentioned earlier, those that are in a nursing facility or ICF-IED level of care, those that have eligibility during a presumptive eligibility process, and those members that are infected with tuberculosis and are eligible for tuberculosis-related services in Sooner Care. We also have our BCC program, Oklahoma Cares, that they will be excluded. Those members that receive a service from a home and community-based waiver service, like Advantage or our medically fragile waiver. Those undocumented persons that are eligible for emergency services only. Our Intra-Oklahoma program, that's a joint partnership between the healthcare authority and private commercial insurance plan that we pay subsidies for those employer-sponsored insurance programs, as well as any pregnancy-related services under our CHIP program for the unborn child, also known as soon-to-be Sooners. So what will the covered benefits be under Sooner Select? I will start off by saying that if a service is covered by the healthcare authority today, those services will also be required to be provided and covered through a contracted entity. In addition to that, so when I say care services now, that's everything. That's medical, that's behavioral health, vision care, as covered today, as well as pharmacy services. We will also have dental services delivered, but it will be through a separate contracted entity specifically focused on dental health benefits. I mentioned earlier, we have the children's specialty plan. Overall, we technically have 3 RFPs. The dental actually dropped on September the 1st. And so the dental, medical, and children's specialty. In addition to the covered benefits that we covered today, we're expecting our contracted entities to really focus on those social determinants of health that we know have such a huge impact on our senior care members' overall health. That means partnering with community-based organizations such as organizations that can help members achieve housing or food stability. We know that in a lot of our areas of the state, people live in food deserts, so they don't necessarily have access to those healthy foods that really have an impact on our overall health. Kevin mentioned earlier, we rank in the bottom 10 across in the nation for obesity, for example. And a lot of times that's just because we just don't have access to those healthy foods. So we would expect our contracted entities to come up with innovative solutions to get those healthy foods and additional services to members where they're at that will have that overall impact on their health. So there's also a requirement that our plans propose during the request for proposal process, the value added benefits and service that they will bring to the table as a contracted entity. Now, there are just as a fee-for-service Medicaid agency, of which we're one of the remaining, I want to say 10 in the nation, to be in a fee-for-service environment as a Medicaid agency. There's just a lot of federal regulations that do not favor a fee-for-service environment for the Healthcare Authority. There's a lot of stuff we would love to cover that we simply can't because of our current payment arrangement. But in a capitated environment where we're paying a managed care entity per member per month, whatever savings is generated through enhanced care coordination and getting those access to primary and preventive care services, those savings can be reinvested into the healthcare of our members. So we can see things that additional services that will address the health and wellness and independence of our members in their communities through these contracted entities in ways that we currently cannot as the Healthcare Authority. So touching on pharmacy really quickly, the Healthcare Authority will still manage the preferred drug list that's utilized by our contracted entities. We also currently participate in a drug rebate program with drug manufacturers. In fact, it's a requirement if a drug is covered that the manufacturer participate in this rebate program. And this means that a lot of dollars comes back to the Healthcare Authority and by way of rebates. Those rebates will still happen, still accrue to the benefit of the Healthcare Authority as we manage the preferred drug list. The main difference is that the payments and the administration of paying those claims from pharmacies and pharmacists will go through our contracted entities once we implement. We will also ensure that our members continue to have access to non-emergency transportation using the current vendor that we use, but it'll be administered through the contracted entities moving forward. Let's talk a second about network adequacy. So we know that in order for a contracted entity and for even the Healthcare Authority to be successful, we need our providers, and we need for providers to be within a certain time and distance of our members to make it realistic that our members have real access to healthcare. So to do that, we have set very specific time and distance standards for various providers and specialty providers, whether it be primary care, cardiovascular specialty, behavioral health. We have very specific, for example, I want to say in our urban area for primary care, we would expect to see that a primary care provider generally be within 10 miles of a member's residence. There's very complicated ways of achieving that and monitoring and overseeing that process to ensure that we do have a delivery network that's adequate. But this is going to be very important and crucial as we move forward for the plans to demonstrate network adequacy to us, and then for us to then demonstrate that to our federal partner CMS before we can go live with Senior Select next year. mentioned earlier, one of our main goals, of course, is to really increase the quality and care coordination and overall population health by going to Sooner Select. So what does that look like? As I mentioned earlier, within the request for proposal and the resulting contract that we will have with the contracted entities, there's going to be very specific goals and milestones that we're expecting to see in terms of achieving certain quality outputs. So one of the ways of ensuring this is that we will have an annual independent external quality review by a contracted entity of the healthcare authorities that will really just validate all of the information that's given to us by the plans. That will go in and look at all these plans on an individual basis and then report back to the healthcare authority to say whether the plans are actually meeting the objectives that are required of them. We will also have ongoing comprehensive quality assessment and performance improvement programs. Have annual consumer assessment of healthcare provider and system survey, otherwise known as CAPS. That is really just a member survey that goes on annually. I will say that the healthcare authority did one of these surveys of our members earlier this year, so we could have good baseline data moving into a Sooner Select model to see where we're starting at and how our contracted entities can help the state even go to the next level. There will also be 3 performance improvement plans conducted annually for each plan. A performance improvement plan can look like a lot of different things, but it's essentially, here's a topic we want a plan to address. Maybe it's focused on, like I said earlier, more access to healthy foods. How can they do that? What's an innovative approach that a plan can utilize to ensure more access to that? And then over the year, they would implement it and then test it and evaluate it, see if it worked. If it does, maybe it's something that they would want to expand more broadly throughout their plan and throughout their memberships, or maybe it's something we want to start implementing across all of our contracted entities in the following year. The performance improvement plans will be a collaboration among the plans and the healthcare authority. We will also reserve the right to require certain PIPs. They won't just be at the discretion of the contracted entity. So the Quality Advisory Committee, through Senate Bill 1337, there was established a Quality Advisory Committee. They have the power and duty to recommend quality measures to be used by our contracted entities. Kind of going back to our performance improvement plans, I would highly expect that this committee would have some input onto maybe what those PIPs would be, advising the healthcare authority on what they should be, what's important, what have our members seen throughout our state and communities that we really need to focus on in terms of addressing quality and outcomes. These members will be appointed by the healthcare authority. They are representatives of our provider community, our hospital communities, healthcare community at large, and those with academic community or subject matter expertise. I will say that we did have an open application process that ended around September the 9th. We did receive a lot of applications. I want to say, around 50. So we're currently in the process of looking at those applications and should have a final committee established by the next week or two. After that, I'm sure we'll get that group together fairly quickly so they can start thinking about those first year quality metrics that we want to bake into the RFPs and how we can enforce those. Just a note about the Quality Advisory Committee, it is subject to the Oklahoma Open Meetings Act. And if you are chosen as a member, apologies, but we are not allowed to give compensation or travel reimbursement for your participation. All right, so provider incentive pool. I've mentioned several times Senate Bill 1337. A very important companion piece of legislation to that is Senate Bill 1396. And that authorizes the healthcare authority to use our current supplemental hospital offset payment program fee, otherwise known as SHOP, to support healthcare quality assurance and access improvement initiatives. Now, a brief explanation of what this is. Our SHOP program has been around for over 10 years. That is, the way that works is it's a supplemental payment where participating hospitals pay in a certain amount or a fee to the healthcare authority based on a complicated algorithm, but it's basically based on volume or number of bed days. They pay that fee to the healthcare authority. We then take that fee as state dollars and then use that to pull down federal dollars from CMS to then bring down additional money and then redistribute that to our participating hospitals, which results in a supplemental payment to our hospitals. This has been really vital over the years in ensuring that we continue to have access to those hospitals, rural hospitals, where we know a lot of the life-saving care takes place. So what 1396 does is change the way we calculate that methodology in order to bring more dollars into the state. So right now, there is a gap between what Medicaid Sooner Care pays for hospital services and what Medicare would pay for the same or similar service. What Medicare would pay is currently our upper payment limit or the ceiling of that gap. Essentially, by going to a managed care environment, the federal law says that we can now raise the ceiling for that gap up to what an average commercial rate would be. So we know average commercial rate on the commercial market is even going to be higher than Medicare. So it's increasing that gap. So it's also increasing the dollars that we can redistribute to our Oklahoma providers. Close to the tune of around $500 to $600 million annually in additional federal funds that we can then redistribute not only to our hospitals, but also to providers like primary care providers and other providers in our communities that are providing those services. We're currently in the process of determining a few things and defining a few things, primarily around what is primary care, what's considered to be primary care, what the provider pool is going to look like. We will have some more stakeholder engagement specifically around that topic, and we will also engage in with some consultants about how best to calculate that and move forward. All right, financial. I touched on this earlier, but we will be moving in this model, moving to a fully risk-based capitated contract, which will be approved by our federal partners at CMS. So really what this means is we are looking at several years worth of historical claims data to give us our costs, and then we will break those costs up into various population segments. So just to give you a simple example, we now have a year's worth of claims experience for our expansion population. So we have a year's worth of claims to say, here's the cost that we would expect of our expansion adults. We will use that information and then marry that with some predictive for predictions around growth and utilization in the program for the next year. And our actuarials are looking at that and boiling that down into a per member per month rate that we would pay to a contracted entity to cover all of the services required for those members. So this is risk-based. So there will be a PMPM that's for everyone in the expansion population in that plan. We understand that some members may go a month with no service, but we know that some members may have a month where they have an exuberant amount of services. But in the aggregate, excuse me, it will level out, and it creates cost predictability for the healthcare authority because we know on a monthly basis how much we will pay our contracted entities. These rates will be actuarially sound. I mentioned we do have a consultant calculating these rates for us. They are, for the dental RFP, for example, they are currently posted on our webpage in draft form. We will have to go through another phase where those actually get certified. And they will no longer be draft rates. And then we will submit them to our federal partners for review and approval prior to go live. Third bullet here mentions a withhold agreement, and this ties back to our quality initiatives as well. And so what we're saying with a withhold agreement is we know that there's multiple ways to ensure compliance from a contracted entity. One of those is through a withhold. And essentially what we're saying is, okay, contracted entity, we're going to hold a portion up to, let's say, in the 2% range of your total capitated payments for that year. We're going to hold on to that. And when you've demonstrated that you've met those quality outcomes or metrics or targets at the end of the year, we're going to give it back to you in an amount that is proportionate to the targets that you met. So it's really just one of the tools in our toolbox for ensuring compliance with our contracted entities moving forward for the various requirements throughout the contract. Payment rates and timelines. So this is specifically regarding payment rates between a contracted entity and our participating provider network. So the main difference here in the Sooner Select model is that currently our providers are very used to contracting with the healthcare authority. You submit your prior authorization requests to us, you submit your claims to us, and we pay those. Moving forward, the relationship with our providers will be directly with the contracted entity. So you will submit your claims to the contracted entity, your prior authorizations, the communications around approved and denied claims and remits will all be between the contracted entity and the participating provider. But we wanted to make sure, not only in contract, but it's also a requirement of Senate Bill 1337, that our providers be paid a reasonable rate as they are now and have been historically through the healthcare authority. One of the protections that we are baking in there is the rate floors that will for our fee-for-service services that will be in effect for providers until July 1st of 2026. This is really just to ensure a couple of things: that our contracted entities have adequate networks moving forward, and that we give our providers enough time to enter into value-based payment arrangements with our contracted entities. We know that's not going to happen day one or overnight, or maybe even in the first year. So we wanted to allow for a sufficient window of time for providers to really get educated on value-based payment methods and working with their contracted entities to enter into that. Now, we know that there may be some anxiety or maybe just fear of the unknown when it comes to what is a value-based payment methodology. What does that mean for me? Does that mean I'm going to start being paid less fee for service? What's the direct impact? I will say that we are setting very, very realistic targets for our contracted entities in terms of achieving value-based payment relationships with our participating providers, because we know it's going to take some time. A lot of times what we see is our provider community is providing excellent service. They're achieving those outcomes for the members, but we just don't know that at the healthcare authority because all we get is a claim for a service. So we know those first few years are really going to be more administrative in nature and really learning how do I report these things? Or did my contracted entity give me a resource now that I can begin reporting certain measures and reporting those outcomes that the members I'm working with are achieving, so I can get credit for that? So for the first couple of years, we're really probably going to be more of a pay for reporting incentive with very little risk shared by the actual participating provider. We also know we have various federally prescribed payment methodologies that will continue to be protected throughout the Sooner Select model. That's our federally qualified health centers, our rural health centers, pharmacies, Indian healthcare providers, and emergency services. All right, timeline. When is this happening? When can you expect to be impacted? So we have an expected RFP release date. We say early fall here. I mentioned earlier that the RFP has already been released for dental on September the 1st. We expect for the medical and the children's specialty plan to be released within the next few weeks, probably towards the end of October. We are anticipating a launch date of October 2023, just right at a year from now, of course, pending CMS approval. I mentioned earlier that our capitated rates have to go to CMS for approval. Essentially, everything we're doing along this journey will have to be sent to our federal partners for review and approval. Our RFPs, our resulting contracts. After award, we will have very intensive implementation sessions with our partners, which will also result in a readiness review. Once the readiness review portion is completed, we will then submit those results to CMS, which will include a very robust analysis of network adequacy requirements. And not until all of that is approved by CMS can we implement Sooner Select. So we have a very tight timeline. We know it's going to be fairly aggressive for us to get there, but we're confident on the state side that we're doing and will continue to do everything we can to make sure that we can meet that October 2023 implementation date. All right, so I see, I'll go to the Q&A here. All right, let's see, Ms. Savage, the first question is, how will a baseline be established for practices that have a majority of chronically ill patients who may be first time insured as adults? So a lot of this is really going to be calculated in the aggregate, looking at the population across the state or across a health plan in particular. And that's how we'll achieve baseline status, not necessarily just those members being served at a particular clinic. We know that some clinics, especially safety net clinics, will see kind of a disproportionate amount of higher need individuals, but by establishing baseline, that's more the aggregate, we really can address it from that angle. Here's a question: how will we share information between providers? We'll be uploading charts, document labs to platform for sharing. So I will say a couple of things here. If you have an electronic health record currently, there will be an expectation kind of on a parallel track that providers begin participating in the statewide HIE at some point next year. But there will be a lot more communication around HIE requirements at a later time. But yes, there will be some level of information sharing there that the contracted entities may have different ways of collecting that data that can then be shared. As a pediatric physical therapist who has seen a decrease in reimbursement, I am concerned that the administrative costs, financial and time, will increase. How do you see this concern? What recommendations do you suggest to help minimize the impact of increased administrative, financial, and time costs? This is one of those I'm glad you asked, because there's a couple of things I forgot to mention. And a lot of things we learned last year during this process that really impacted provider practice that we feel like we are addressing better this year. One of those is a single provider portal that you use. We will require all of the plans that contract in Sooner Select as a contracted entity to all agree upon and utilize the same portal for claim submission, prior authorization submission, eligibility verification. All those things that you use for the Sooner Care portal for now will be one. So if we have, like I mentioned earlier, 3 statewide plans and you're in Tulsa, and we also have an urban plan in Tulsa, that's potentially 4 plans you may be working with. You would just have one single portal to be able to submit all that through. So you're not having to learn and juggle a bunch of different portals for our providers. So we hope that's one way to reduce administrative burden. The next, we know that credentialing can be a burdensome process if you had to do that for 3 or 4 different plans. So what we have done is also along the same lines, requiring that our contracted entities agree upon and utilize one credentialing verification organization across all the plans. So you will still expect to come through OHCA provider engagement, fill out your enrollment paperwork, go through our screening, and then go through one credentialing verification organization that all of the plans will have to accept that decision. So we know it's going to be a change, and it's going to be a change in how maybe your workflow is at your particular practice. But we hope there's a few things we've done this year to help reduce that. See, there's a question where to find the most recent member quality survey, as was just mentioned, since it's baseline. We're still preliminarily dissecting that. We have our initial results back. We've seen a kind of initial take on it, but we want to kind of refine that, finalize it before we post that moving forward. Let's see, in the last town hall, you may mention another contracted entity having the option to assist by a family by possibly providing a window unit for a family in need. Do you have any idea what a special request such as that would look like, or would that be determined by each contracted entity? Yes, the latter. That would be something that would be, excuse me, decided on by each individual contracted entity as a value add. Now, as a value-added benefit, the healthcare authority would need to see those and approve them, but we don't have a lot of discretion in requiring them. So we will give them lots of space to be innovative, to do what they need to meet those member needs. So it will be addressed individually by each CE. Will the developmental disability service division clients be excluded from the program? Yes. So our DDSD folks are being served by a waiver, and those are excluded from Sooner Select. So how will we as a provider know who the contractors will be for each patient? Again, that'll go to that single provider portal that you'll go into. There will be a way to verify eligibility as a way to identify which plan that member is affiliated with. How will the transition affect ambulance reimbursement and billing for emergency and non-emergency transports? Ambulance providers will be reimbursed through a contracted entity. So we would expect that our CEs would contract with our ambulance network of providers throughout the state and be responsible for administering the payment of those claims. I don't believe this was covered. What is the timeline for the contracted entities to be announced? What is the timeline for providers to be contracted? So announcement, the timeline right now is we expect to have dental contractors announced probably late February, early March, and then awards for our medical program probably towards the end of April of 23. Second part of that question was when will providers start getting contracted? I highly suspect that a lot of the potential bidders for the medical program, as well as the dental, are already probably calling some of your offices, asking for letters of intent, wanting you to sign something that says, I intend to be a contracted provider, because they're going to have to show some level of network adequacy going into the proposal process. But it's not until award of those contracts and they have an official agreement with us, again, that kind of late April 2023, that we would expect them to start really getting really aggressive and building out their networks and issuing those contracts with you all. Will each managed care company have their own prior auth requirements, rules, et cetera, so that providers have to know rules from 3 to 4 plus plans? This could result in increased administrative tasks and resources for the providers. I will say that they will use very similar requirements as the healthcare authority uses today. They cannot be more restrictive in terms of their medical necessity criteria and prior authorization guidelines, unless we as being the healthcare authority have reviewed and approved those. There's also requirements within the RFP that those plans work with each other, meaning work across plans to make sure that there's consistency there to really reduce provider administrative burden and having to operate from 3 to 4 different sets of guidelines among the plans. It seems unwinding and start of Sooner Select may overlap. Is it still true that the public health emergency protected members will not be involved in Sooner Select? So real quick here, the public health emergency, as we all know, we're still under it, and there's certain protections for members while we are under a public health emergency due to coronavirus. One of those protections is that we have continuous eligibility and we cannot disenroll any members until the end of that public health emergency is declared. Because of that, we currently have around 250,000 Sooner Care individuals that will no longer be eligible for the program at the end of the public health emergency. As soon as it's declared that it's over, we will begin around a 9-month unwinding process that, you're right, may overlap a little with that October 2023 go live date. We have talked to CMS about this, and they've given us verbal assurances that we do not have to transition those members into Sooner Select. So they would remain in a fee-for-service environment until completely unwound or disenrolled from the program. Will there be a meet and greet for providers to meet with the insurance companies and look over the different Select plans before we sign up for the different ones? Yes. So if you were involved in this process last year, you'll remember we had a series of regional town halls where we invited members of the public and community providers to meet with us and our contracted plans. We do plan on doing that again. We kind of wanted to do a little differently this year and kind of bring you, get your input as we craft the RFP, but we will also have a very similar situation, maybe more so live and in person with our plans. So you can meet them and talk to them and ask all those questions prior to becoming a provider. Will the new system have a cap of annual visits, or will it be based on the medical necessity recommendation by the licensed provider in the evaluation report, such as pediatric therapy and outpatient? Those, as I mentioned earlier, those caps cannot be more restrictive than the healthcare authority currently has today for each individual service. Will this transition expand or decrease ambulance coverage benefits for current beneficiaries? Will it expand or decrease the number of covered beneficiaries? Addressing the second part of the question, it will not add more covered lives. So the healthcare authority will still be determining eligibility. We will still be in charge of that. The plans will have nothing to do with enrolling members into the Medicaid program. In fact, they also cannot do direct marketing or solicitation to a member or a potential member in their plan. That's actually prohibited federally. What we will do is kind of transition our current member services staff into a choice counselor role so that our members can call in, have someone to talk to about the various benefits offered across the various plans. We will have very robust member benefit comparison guides for them to review to see maybe one plan has certain value added benefits that may be more important to their family than another plan. So we will work with them to identify a plan, and we will still maintain that eligibility. Let's see. In behavioral health, will private LBHPs that are contracted with the contracted entities continue to only be allowed to see children and paid at a lower rate? I will say contracted entities will have more flexibility here. There's an emphasis within the RFP around integrated care, and we know that's not only going to happen at a community mental health center, but also really should be happening in a primary care environment. So we put an emphasis on that, and that can definitely be a value-added benefit that a plan be able to reimburse for additional populations like those adults within an integrated primary care setting. They also do have flexibilities, again, to go above what we currently reimburse. They cannot go below, but they do have discretion to go above or come up with other incentives for providers to participate. With just a 60-day sign-up period, when will members know about making a contracted entity choice? Where will members get the info in choosing among CEs? So the 60-day sign-up period, prior to go live, we will allow an initial 60-day time period for members to make a choice as to plans before we go live October 1st of 2023. Members that have not made a choice within that 60-day period, they will go through a very simple auto assignment algorithm process that will take factors into account like alignment with the primary care provider, keeping families together on the same plan, for example, and ensuring that all those things are taken care of. And then after assigned or even after choice voluntarily, a member will have 90 days to then select another plan. Let's say they got into a plan, later realized their primary care physician, the one that they wanted was not in it, or they want to change. they can change their plan selection within 90 days. Now, after that 90-day period, however, they are locked in until the next re-enrollment period. Will the capitated payments replace the monthly care coordination payments? Will they be monthly or quarterly? So the capitated payments will be between the healthcare authority and the contracted entity. I can only assume that the capitated payments you're talking about now are within our patient-centered medical home or senior care choice program, where the healthcare authority pays around $5 per member per month for your choice panel members. We will no longer have that direct relationship with you as a participating provider. That relationship will be between you and the contracted entity. There is emphasis on the medical home model, but how to get there and achieve that will be between the participating provider and the contracted entity. Will the state have a neutral third party that providers can appeal utilization review determinations made by payers when they disagree with payer determinations? So I will say the initial administrative appeals process will now go through the contracted entity, much like you do now when you have disagreements with the healthcare authority, you go through our administrative process. That will now go through a contracted entity. There are limited circumstances where a member or a provider could request, I believe, a state fair hearing, where the healthcare authority would be the final arbiter of some of those decisions. How would urgent care locations be reimbursed based on outcomes? Value-based payment methodologies and outcome-based payments methodologies are going to look very different among the various provider types. That's really going to come down to those provider types and the contracted entities on how they achieve that. Now, the way we're requiring value-based payments and the targets that we've set for the contracted entities are not necessarily by each discrete individual provider type and specialty. It could be more of in the aggregate, so much percentage of claims being reimbursed by a contracted entity are done so through a value-based payment arrangement. So we understand that a lot of time, like an urgent care center or a crisis center, they're seeing clients at their highest acuity, highest need, and there's not a lot of impact other than de-escalation and stabilization that they can achieve in that small time frame, and we understand that. Let's see, is it known yet how the transition may affect the graduate education medical payments and the supplemental payment program? Yes, we have a list of supplemental payments that we administer now through our graduate medical institutions as well as our teaching hospitals. Those will continue to be provided for and paid to those entities through what's called a state-directed payment program. So essentially, we continue to calculate that, but we pass those dollars through our contracted entities to be reimbursed directly to those providers. So we will continue to preserve those supplemental payments. Is it true that AIAN members that are self-identified tribal members be auto-enrolled rather than having the opt-in provision? If we have an AIAN member that is self-identified and they are identified in our MMIS system as an AIAN member, they will be able to choose to opt in rather than opt out. Does OHCA have sufficient staffing and resources to manage so many contracts and utilization standards for MCOs? OHCA has been a great partner, especially for safety net organizations. The hope is that such an accelerated timeline for such massive change in the delivery system that OHCA can maintain its quality. We know that with every major transition to any kind of large-scale project, there's going to be bumps along the way, and we're grateful to our providers that can hang in there with us and work with us as we work through some of those bumps. But we are confident that over the next year, not only do we have internal staff that will start shifting the way they think and operationalize things, but we have the help of some very great consultants. We're looking at more kind of IT technology solutions that can help us do this, because we know a lot of these commercial plans, especially if they're successful in their RFPs, bring a lot of savvy and expertise in this delivery service model that we don't have. So we understand that, and we're preparing to be able to do that effectively starting day one. But we understand the concern, and we're grateful for our providers to work along with us in that journey. Last question here is, how will the CEs work with children's vaccine program? We will require that they go through the OSIS portal, work with our State Department of Health, as well as all of our other sisters agencies, and continue to participate in the VFC program. All right. It's the last question I've seen come through the portal. So I appreciate you all attending today and all of these. I will say this is our last town hall, and it's been fun, and we will more than likely see you in the spring when we have those partners announced and you can come meet them. All right, Kevin, you want to close this out?
Yeah, thank you, Trailer, and great job. And I know everybody here appreciates everything that you've provided today. Is very full and wholesome, thorough on that basis. Thanks for everybody being with us today. I know we threw a lot of information at you. Hopefully, we were able to answer your questions. We appreciate the feedback that you have. If you have others, please continue to provide that to us. And we'll continue to keep you updated on the progress we're making on this medical RFP. As Trailer mentioned, our intent is to get this out before the end of October. And we're certainly committed to doing that. So with that, I'll say thank you and have a great day.